I am Josphat Maina. I work for the National AIDS Control Council here in Kiambu. I support AIDS coordination in Thika sub-county. I have worked a long journey with Listen since it was under the name Business Process for Impact. It was introduced to us after NAC realized that we had a lot of issues with regards to our adolescents and young people. And we had very many meetings to be able to really be able to identify where specifically our problems are and what were the opportunities for us as a county to be able to address issues of adolescents and young people with regards to issues that affect them. And what we realized is what we thought were the issues that were grappling, the youth were grappling with. We came to realize that the issues were very different when we came to uh, prioritizing issues with them. And we tried to see how we can be able to work together with them and the people who interact with them and from where they were in terms of their service delivery point, so that we could be able to make it easy for them and for us and to be able to kill more than one bird using one stone. The burden for HIV in Kiambu is about 52,816 people living with HIV. But of course, the ages that are 15 to 24 and 10 to 19 bear the biggest burden of HIV. And what we realized as a main drivers of the epidemic, number one is issues of poverty, because some of them were engaging in sex commercially, transactional sex. Some others were doing sex with people to just see how they could be able to get livelihoods out of that. Issues of mobility. Kiambu, our infrastructure is quite well developed, so it's possible to find a young man here and find them in another place in a few minutes. And the issues of the key populations, we have very young key populations, and the numbers are coming up in Kiambu as we talk with regards to MSMs, male who have sex with men, and female sex workers, and even men who have sex with other men. So those numbers are coming up, and the concentration of HIV among that population is always very, very high compared to the 2.4% of the HIV prevalence amongst the general population. Another factor is the high number of adolescents and young people that we have in Kiambu. We have about six universities, and you can imagine people from all over come and congregate in Kiambu in those universities to come and learn. And we also have very many tertiary institutions that might not be universities, but many other colleges and vocational training institutes. So we have, during admissions, we have very high numbers of young people who are coming in. For example, this year, starting in January, we got around 40,000 who are coming in just one sub-county. So you can imagine 40,000 young people coming in one sub-county, and the kind of interactions they're going to have with the population, it's quite a huge number of young people that we're talking about. So those are partly part of, and issues of alcohol and drug abuse is very rampant in Kiambu, and we cannot really divorce HIV infections and alcohol and drug abuse. So those are partly part of the issues. And another thing that I might want to mention is that we do not have targeted or deliberate interventions that were specifically for adolescents and young people before BPI came in. And we have now tried to adjust and customize our services to be able to see how do we make them more responsive and more friendly. So when BPI came, we had a long journey with it. We started with talking and looking for blessings from the then governor, and trying to explain how the BPI is going to help Kiambu. We got his blessings. We sat with the NAC and Georgetown, and we got capacity from the technical team to be able to really understand our youth deeper, so that we could be able to see where we could be able to come in. After that, we were able to identify a few communities of practice that were mostly CPs who had young people and people who really interact with the young people on a very regular basis, so that we could see how we could take advantage and be able to find opportunities to address HIV and also address other non-health issues, because you realize that there could be some formations that we have not taken advantage of, and we realize that these formations could help us be able to reach our young people. So that is what happened in the pilot phase. We had some challenges in the pilot phase because the way BPI came in, it was a bit theoretical, it was a bit abstract. So to make it implementable, we tried to really find ways of understanding it and making it something that can be implemented, but we were able to go through the pilot phase. But the other major challenge that we had was the issues of data collection, because we had lots of qualitative data and qualitative information. So we gave very many qualitative reports, but we didn't have a lot that was quantitative. And I think that is a challenge that we try to see how we could be able to overcome it in the next phase, which is listen. And I can see that we have now been able to come up in a big way in terms of how do we now come up with quantitative data that we can also be able to use in decision making and be able to give us a clear reflection of what is actually happening on the ground. So with Listen, we have also adopted the human-centered design, so that we do not bring in boardroom solutions, but we come to the community, talk to them, be able to work with them and work with them to be able to really find out what is ailing them and what are the probable solutions coming from them. And then we just offer a little bit of technical support and be able to come up and refine solutions that they come up with, so that we see how do we now ensure that whatever are the visions and the inspirations of the young people, and as well as we also meet the mandate of the National Disease Control Council in terms of bringing down the new HIV infections. So that is what we are doing now. And currently where we are, we have indicators that we have customized for each and every community of practice. So those are the indicators that you're going to be tracking along the way, and you're going to be doing that online, so that we can be able to get data that is the most current, and data that you can be able to use even in terms of making other decisions other than HIV-based decisions. And that is part of the reasons why we have a meeting, to be able to bring together communities of practice, so that we can have a few champions who are going to also cascade this into their CPs, so that we can have a huge number of people reporting through the online system, so that we can be able to remedy the situation that we were in terms of not having enough quantitative data. LISTEN is an acronym for Local Innovation Scaled Through Enterprise Networks. So what happens is you leverage on opportunities in terms of formations that are already existing on the ground, to be able to see how can we help them achieve their aspirations, as well as for the National AIDS Control Council and the Department of Health to also be able to achieve their mandates. So what we do is take advantage of communities of practice that we have not created, but already existing on the ground, to be able to see what brought them together and what are they doing, to be able to see how can we support them to be able to reach what they can be able to do amongst themselves, and also to establish linkages that could be horizontal and vertical, dependent on the need that the CPs have. So what we are doing is to use local innovations, because they've always been there, but we've not taken advantage of them as a department to meet our health mandate. So that is what we are trying to do. Basically, I can say that a community of practice is a coming together of people who have a specific need that they would want to come together and address. So we did not create those groupings. Like, for example, if I can take an example of the faith sector, they know to be able to spiritually be able to nourish themselves and even be able to take themselves and their flock to the next step. They came together as a group, a pastors movement, so that they could be able to support each other in evangelization. We have another community of practice for the Buddha Buddha. So the Buddha Buddha people realized that they had issues with first aid. They needed support with insurance. They needed support with entrepreneurship and savings and those kind of things. So they formed their own groups, and these are the groups that you're taking advantage. If it is young people, they could maybe have come together because of issues of maybe how do they nurture their talents, how do they also bring together their funds and do something like merry-go-round or table banking. So those are the communities of practice that we are working with in Kiambu. And we realized that those had very, very close and routine or frequent interactions with our young people. So if we are able to go through them, we can be able to reach our young people without necessarily using a lot of resources. So during the activities, we bring in issues, or we bring in people who can be able to address their issues. For example, if it's a Boda Boda community of practice that has like a sports day, we could bring in the insurance people, we could bring in the traffic department, we could bring in maybe investors. We could bring in men who could talk about stigma. We could bring in men who talk about alcohol and drug abuse. So as we address issues that they feel brought them together so that they can be able to address them, we also take advantage and also be able to address one or two agenda for the Department of Health. So at the end of the day, it is a win-win situation for the communities of practice and ourselves. So in Kiambu, we realized that the adolescents and young people, there were quite a huge chunk that was dealing or had very close interactions with the church. So we went for the faith sector, and the faith sector was split into two because we had the faith leaders as well as the young people who are in the church, as well as the Buddha Buddha people, the interactions between the Buddha Buddha people. Some of them, the Buddha Buddha riders, some of them are young people who have very, very close interactions with young people. So due to the fact that some of the Buddha Buddha riders are still among the group that we are talking about, and the interactions, that is the reason why we thought it would be very crucial that we also bring them on board. And then another CP that we also brought on board is a structure that had already been created and working very well in Kiambu. That is the YACH, that is Youth Advocates for Health. And because it was already existing and working in the HIV space, we thought it would be very critical that we also bring them on board. So we're also taking advantage of that, and we are working very closely with them. We also had male champions because we realized that it's sometimes easier for a man to be able to be sent to mobilize and to create demand among fellow men. So because they already had another structure that had been trained and was working under the NAC, although they are not currently supported, we also thought that would be a very critical group that we could also work with. So those are the formations that were already existing, and these are the formations that we're working with as communities of practice. Number one, what I would say is it will be very important for us to be able to build on what the successes were from the BPI. Like, for example, we already know that HIV was almost not a priority. It was not an agenda at the community level. We have been able to now rekindle the debate about HIV and health issues among at the community level. So we'd want to build on that and make sure that when people sit together and talk about savings, they talk about entrepreneurship, they talk about Bible study, they talk about how to nurture their talents, and economic, how to empower themselves economically. They can also have a debate that is very critical, the debate for HIV and how they can be able to even address issues, health issues amongst themselves. So we'd want to ride on that, but what I think is most important is to also ensure that as that happens, we can be able to get feedback of if there are things that are happening on the ground. Can we be able to really document that? Can we be able to get reports on that? And another thing that will be very critical is can we use those reports so that we can have listen adopted other than by other departments, whether they are national or whether they are county, so that they can be able, like maybe the Ministry of Agriculture, they can also be able to use the listen model to see how they can be able to achieve whatever they have not been able to achieve using other methodologies.